And when it comes to things like mammography, ultrasound, and MRI, and evaluating patients, what are your thoughts when it comes to suspected breast cancer across different age groups and risk profiles? Is there one method that works better for a certain group versus another?
Yeah. So mammograms, although uncomfortable, I've been told, are definitely the gold standard when it comes to the diagnosis of breast cancer. People think that MRIs are better, and MRIs certainly have their utility, but mammograms are so important because they especially can be used to detect tiny areas of calcification. They also can be used to look when you have mammograms done over a period of time to look to see if there are slow changes. And by detecting those slow changes earlier and pointing those out and getting biopsies done, mammograms remain the gold standard and they are what is needed for screening. However, um, as we've advanced, we do have other types of imaging modalities. Ultrasounds can be helpful, especially in patients who have dense breasts. So the FDA recently, in the last couple of years, mandated that the density of breasts be reported on every mammogram. And for those that have dense breasts, supplemental imaging with things like ultrasound can be helpful to detect things um, uh, that are of concern that might not have been identified on mammograms. Um, Breast MRIs can also have a utility. Um, Oftentimes, you're plugging patient's characteristics into risk calculators like the Tyrer-Cuzick model. And if you meet a certain threshold, or you have other criteria like you have a known BRCA1, BRCA2 mutation, or if you say have a history of Hodgkin's lymphoma and you've received mantle radiation, these are all risk factors that can significantly increase risks for breast cancer. And so in high risk clinics across the US and other locations, having that breast MRI can be helpful and more closer than once a year monitoring to look for early signs of breast cancer in those higher than average risk patients.
And where do things like molecular and genomic assays fit into your routine practice for early stage disease? And how do they influence decisions about systemic therapy?
So it's exciting times in the treatment of breast cancer, and it feels like there are new treatment options that come up every quarter, which is why going to conferences and staying abreast of current literature allows me to provide my patients with the best care that we have in 2026. Genomic assays have helped tailor um, how we offer adjuvant chemotherapy, so chemotherapy after surgery, in select patients. So the most common subtype of breast cancer is those that are hormone receptor driven, those estrogen, progesterone expressed cancers that do not have HER2 positive disease either. So in those patients, especially if they're lymph node negative and depending on patient characteristics, if they're fit enough to receive chemotherapy, these scores, like the 21 gene recurrence assay known as Oncotype, and there are others as well, can help um, direct the aggressiveness of the tumor and B, how much benefit there could be from giving chemotherapy. So when it comes to chemotherapy selection, having these genomic assays is helpful. There's also in the national guidelines, like the NCCN guidelines, recommendations for the again those type of population, hormone positive, HER2 negative, with the breast cancer index that can help inform benefit of extended endocrine therapy, so beyond 5 years. So these are tools that I use every day in practice.
Mhm. And in which clinical situations are you most likely to consider advanced tools like as circulating tumor DNA or other liquid biopsy approaches, even as they're still evolving?
Yeah. So this is a area of active interest and ongoing research. Areas in which I currently use guideline directed ctDNA monitoring is in my patients with stage 4 or metastatic breast cancer, especially again in that hormone receptor positive, HER2 negative population. When I have patients that are on first or second line endocrine therapy, there can be acquired mutations that arise that allow for more opportunities for other directed agents. So keeping an eye on those when at times of which I need to consider changing treatments is very helpful. We have ongoing research and studies that have shown if you're doing chemotherapy before surgery and you have ctDNA positivity noted in blood work, and if you get the treatment and then you go to surgery and you become ctDNA negative, that can lead to better prognosis. However, ctDNA in the adjuvant setting, so the stage 1, 2, or 3 setting, has not been shown in evidence and is not currently recommended outside of clinical trials to be commonly used. So it's a very, very, very common question I get in practice. And I believe that tests need utility and they need to be able to inform my practice. And I certainly hope, as I continue moving forward, that there will be a study that shows that if we're able to detect things earlier with maybe ctDNA positivity, I can do something about it, change treatment, give additional chemotherapy, and then it goes away. And that shows that patients can live longer. I certainly would be fully supportive and hopeful that one day that study will exist.